Hi guys, good evening. Good evening. Can you all see me? Can you all hear me? Hi guys. Can you all see me? Can you all hear me? Alright. I hope I am audible, I'm visible. Okay. Fine. So let's continue from where we left off yesterday. Yesterday we spoke about the TNM classification of breast cancer, and as promised yesterday, today we'll be talking about how do you stage the disease, and based upon the staging, how do you right. I think hi Saresh, hi NVK. I don't know who that is. When dream comes true. Hi, kya haal hai bro? Okay. Okay. Hi guys, hi. Good evening, good evening, good evening. So let's get it rolling. ठीक है, शुरू करें. So yesterday we spoke about how do you do a TNM classification, and today we'll be talking about staging of the breast cancer. ठीक है. So we'll start with the staging of the breast cancer. So it is going to be based upon your 8th AJCC, that is your American Joint Committee for Cancer, right? So according to the 8th AJCC, we'll be talking about the staging of the breast cancer, right? So we had the same context yesterday, we discussed it. The TNM classification is also in line with the 8th AJCC. For most of the cancers, we follow NCCN guidelines. So we'll be sticking to those guidelines as well. Okay? Right? So now, when you talk about the staging, you have the various stages in the breast cancer. The first one is what we call it as stage 1. Now, to categorize this as a stage 1 disease, how do you know it's a stage 1 disease? Any patient who's going to have a T1 disease with N0 and M0, right? Yesterday we have learned about it. What is T1, what is N0, what is M0? T1 is size less than 2 centimeters. N0 is there is no evidence of any lymph nodes involved, and M0 is no evidence of metastasis, right? Yesterday we discussed it, right? You have T1 where the lesion is less than 2 centimeters in size. N0 is like there is no evidence of any lymph nodes. M0 is no evidence of any metastatic nodes as well, right? I would request Santosh sir to continue the Harrison series as well. I know there's a huge demand and you guys love him. I will convey the same to you. I mean to the sir as well. Chalo. So stage 1, it is going to be T1 N0 M0. Right? A stage 1 disease is going to be a T1 N1 M0. Next, moving on to the stage 2 disease. So in a stage 2 disease, now it is going to upgrade. It is going to be T2 N0 M0, or it could be T1 N1 M0, or it could be your T1 N1 M0, or it could be T0. There is no evidence of any node yet with N1 and M0. It will be called as stage 2 disease, right? So specifically it is an early form, we call it as stage 2A disease. Now another stage that you have is your stage 2B disease. So in a stage 2B, it is going to be an upgrade, right? T3 N0 M0, as you can see how it is moving up. T1 N0 M0, T2 N0 M0, T3 N0 M0, stage 2A and 2B as well, right? Now then you become T1 N1 M0 was 2A, it will become T2 N1 M0, right? It is going to be your T2 N1 M0. So it is either T3 N0 M0 or T2 N1 M0. It is going to become stage 2B disease, right? The next set of disease that you're going to have is going to be stage 3. So in a stage 3 disease, we have stage 3A. Now what classifies as stage 3A? Either it is going to have a T0 but directly N2 M0. Either it is going to have T1 N2 M0. or it is going to have T2N2M0, or it is going to have T3N1M0 or T3N2M0. Any of this will be considered as stage 3A. Okay, quite simple. Hi Munir, good evening, welcome. So stage 3 is going to be predominantly it is an N2 disease. Okay, agar N2 ho gaya, it is going to be stage 3A. Then going to stage 3B disease. Then going to stage 3B disease. In stage 3B disease, it is going to be T4N0M0. It is going to be T4N1M0. It is going to be T4N2M0. Right? Any of this will become stage 3B. Then comes the stage 3C. Then comes your stage 3C. 3C is going to be NET, that is T1 to T4, but N is 3NM0, that is N3M0 will become stage 3C. And the last one that you have is going to be our stage 4. Stage 4 disease, a stage 4 disease, it is going to be NET, NEN, if M is going to be 1. If M is going to be 1, this is going to be considered stage 4 disease, right? So this is how you're going to stage this is how you're going to stage our breast cancers, right? So any patient of breast cancer will be staged on the basis of these parameters that we have evaluated. So yesterday we learned about TNM कि कैसे करते हैं TNM, फिर आज देखेंगे कि stage wise मतलब इन TNM के combination के हिसाब से कौन सा stage बैठेगा. ये I know it's a lot of information, ठीक है? तो as a student आप कैसे याद रखोगे? एक simple सा आपको trick देता हूँ. देखो 3A 3B 3C में trick होगा. तो 3A को याद रखने के लिए याद रखना ये N2 डिजीज है. 3B को याद रखने के लिए याद रखना ये T4 डिजीज है. 3C को याद करने के लिए याद रख लेना ये N3 डिजीज है. एज सिंपल एज दैट. ठीक है. अगर आपको T2 आई मीन इफ यू आर गेटिंग एन N2 डिजीज इट इज गोइंग टू बी अ 3A. इफ यू आर गेटिंग अ T4 विद N2 मतलब T4 जड़ गया उसमें तो इट इज गोइंग टू बी 3B. लेकिन डायरेक्टली N3 बन जाएगा. इट इज 3C. इफ यू रिमेंबर दिस यू विल नेवर गो रॉन्ग यार. 3A में N2 होगा, 3B में T4 होगा और 3C में N3 होगा. बस इफ यू नो दिस यू नो how to stage your disease. बाकी तो लॉजिक है ना यार. T1 N0 M0 will become stage 1. इसका अपग्रेड क्या होगा? T2 N0 M0. इसका अपग्रेड क्या होगा? T3 N0 M0. सो T1 T2 T3 स्टेज 1 2A 2B खत्म. ठीक है. ये आपका स्टेज 1 हो गया, ये आपका स्टेज 2A होगा, ये आपका स्टेज 2B हो गया. देखो लिम्फ नोड में क्या लगता है, अगर स्टेज 1 होगा तो N0 हो जाएगा. स्टेज 2A में भी इट विल बी आइदर N0 और N1. स्टेज 2B में भी N0 और N1. इतना ही कॉम्बिनेशन है. ठीक है. तो यू डोंट नीड टू वरी पर से. सिंपल सा याद रखना. T1 डिजीज विद नो लिम्फ नोड्स इज स्टेज 1. T2 डिजीज विद नो लिम्फ नोड्स इज स्टेज 2A. T3 डिजीज विद नो लिम्फ नोड्स इज 2B. खत्म. ठीक है. इसके साथ अगर ज्यादा दिमाग माथा पच्ची करना है 3A 3B 3C याद रखेंगे. 3A के लिए N2 है, 3B के लिए T4 है, 3C के लिए N3 है. खत्म कहानी. और आपका है ही कुछ भी हो ना हो, अगर M1 है इट इज डायरेक्टली गोइंग टू बिकम stage 4. So it is going to be your metastatic breast cancer. This is the basic concept about how do you stage a disease. ठीक है. एक बार staging आपकी strong होगी ना, अब आप stage wise management के लिए ready हो. Right? So we're talking about the stage wise management of the breast cancer. This is stage wise management of breast cancer. It is the stage wise management of the breast cancer. So if you have seen we have divided, जब हम पढ़ भी रहे थे हमने 3 ग्रुप्स में डिवाइड किया हुआ है. राइट. हमारा ग्रुप नंबर 1 था स्टेज 1, स्टेज 2A एंड स्टेज 2B. ये आपका एक ग्रुप हो गया. देन हमारा दूसरा ग्रुप था स्टेज 3A, स्टेज 3B और स्टेज 3C. सो 3A 3B 3C हमारा दूसरा ग्रुप हो गया और स्टेज 4 हमारा तीसरा ग्रुप हो गया. राइट. सो देयर आर 3 डिफरेंट ग्रुप्स दैट वी हैव क्रिएटेड. नाउ यू नीड टू अंडरस्टैंड दैट योर फर्स्ट ग्रुप वेयर यू हैव 1 2A 2B, this is what we call it as the early invasive breast cancer. This is what we call it as the early invasive breast cancer. This is what we call it as the early invasive breast cancer. Then you have 3A 3B 3C. This is what we call it as locally advanced breast cancer. This is what we call it as a locally advanced breast cancer. Then you have stage 4, which is called as an advanced breast cancer. This is what we call it as an advanced breast cancer. Right. So you have 3A, 3B, 3C as one series and stage 4 as another one. So stage 1, 2A, 2B is what we call as early invasive breast cancer. 3A, 3B, 3C is what we call as locally advanced breast cancer, and stage 4 is what we call it as advanced breast cancer. This is what we call it as an advanced breast cancer. Now, once you have laid the foundation, that you now categorize them into 3 different components. So you have locally advanced breast cancer is commonly called as LABC. So this is the commonly used term that we'll talk about. LABC, 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 that is your locally advanced breast cancer. Okay? So based upon this, you will have your treatment protocol as well. Now, let's talk about how do you like to manage, right? So we start with the management of early invasive breast cancer. You have the management of early invasive breast cancer. So when you talk about the management of an early invasive breast cancer, as we all know, for this it qualifies as stage 1, stage 2A and stage 2B, right? This classifies as your early invasive breast cancer. Now, early invasive breast cancer is actually a very good stage to be in, because if you do it, that is an early presentation. If you treat it early, the prognosis is also good. In that way, it is quite better. So what are you going to do? Now, we have a stepwise approach for any patient who is going to present to you with early invasive breast cancer, any breast cancer. The first step, it is going to be offer a patient surgery. Now, the surgery that I can offer is 2 contexts. Number 1, I can offer the patient a breast conservative surgery. I can offer a patient an offer of breast conservative surgery. Another one is going to be a simple mastectomy. So we'll talk about in detail about these surgeries. In a breast conservative surgery, we are going to remove a small lump that is going to be around with normal breast tissue around it, is what we call it as the breast conservative surgery. Now, there's a small controversy around ki breast. See, we'll have a detailed lecture tomorrow on the breast surgeries per se. But remember, the breast conservative surgery is basically an example of a wide local excision. It is going to be a wide local excision with post-operative radiotherapy. With post-operative radiotherapy, a post-operative radiotherapy to the operative site. To the operative site, right? In simple mastectomy, you remove the breast per se, but you don't need to remove lymph nodes. Tomorrow we'll discuss in detail about what do you mean by a simple mastectomy. But today you remember, just you're going to remove the breast alone. Okay? Now, when you mean by wide local excision in this context, if you take this as the representation of the breast, right? And let's say this happens to be the nipple airlock complex, and let's say this is the axillary tail of Spence, right? Now, there is a lesion which is going to be present here. There's a lump which is present here. So, in a wide local excision, I'm going to take some amount of normal tissue, and along with this, I'm going to remove this. Now, when you excise this entire context, right? So, when you take this entire thing out, this is what we call it as breast conservative surgery. Now, once you have done with this, once you're done with this, now you're left out with a defect here, right? Now, there's going to be a different surgery that we're talking about. There's a huge defect which is present here, but now this will also be marked with clips. So there'll be clips which are going to be present. Now, what are these clips? No, they are radio opaque clips, right? Now, why do you want it? Because this is the site where you have to give radiotherapy. So you're marking that site for radiotherapy, and this is what we call it as marking is done. Now, this is, so post-operative radiotherapy has to be given here. Without giving a post-operative radiotherapy, it will simply become a wide local excision. It will not be called as breast conservative surgery. So there are two options, either to go with breast conservative surgery or simple mastectomy. Simple mastectomy mein patient is going to lose the breast. So cosmetically it is poor looking. Breast conservative surgery, you are able to restore the breast, so patient is quite happy, right? Now, how do you restore it? We'll talk about it also, but before we move further, what are the current indications for breast conservative surgery? Not every patient can be offered a breast conservative surgery. So what is the current indication for BCS? That is, BCS stands for breast conservative surgery. Now, the first and foremost important, the size of the lump. The size of the lump should be less than 4 centimeters. The size of the lump should be less than 4 centimeters. It should be limited to one quadrant. It should be limited to one quadrant. That means it should be, the lesion should be in one particular quadrant. That means when you divide the breast into 4 different quadrants, as we have done yesterday, a lesion should not cross a quadrant. It should be limited to one particular quadrant, right? Then it is called as like limited to one particular quadrant. Now, along with that, okay, so the size less than 4 centimeters, it should be limited to one particular quadrant. It should be a solitary lesion. If it is multifocal, or it is, if it is multicentric or multifocal disease, either ways you should not opt for breast conservative surgery, only for solitary lesion. There should be no evidence. There should be no evidence of lymphovascular spread. Now, if it is found to have spread, then I'm not going to operate. I mean, for breast conservative, I'll be going with more radical approach, not with the breast conservative surgery, right? So size should be less than 4 centimeters. It should be limited to one quadrant. It should be a solitary lesion. There should be no evidence of lymphovascular spread. And remember, patient should be a non-pregnant female. The reason I'm saying very specifically about not being pregnant is, remember, radiotherapy is contraindicated during pregnancy. So this cannot be done during the pregnancy, because without radiotherapy, breast conservative surgery is incomplete. You have to go and deal with that, right? So these are the current indications. If the patient gets satisfied into this, you can definitely go ahead and do a breast conservative surgery. If patient does not fall into this category, then you go with simple mastectomy. Now, the only advantage for the breast conservative surgery, it is going to be with respect to cosmesis. So when you look at the comparative data between these two, breast conservative surgery has a better cosmetic outcome. It is going to have a better cosmetic outcome. When you talk about simple mastectomy, it has got poor cosmetic outcome. It is going to have poor cosmetic outcome. Now, the only thing is the risk for recurrence. I'm not saying it is bad, but the risk for recurrence is slightly high in your breast conservative surgery, whereas risk for recurrence, whereas the risk for recurrence in these patients with simple mastectomy is less, right? Now, if you have understood these concepts, there are two questions that are usually asked, or I can say two scenarios rather. Now, the first scenario is, let's say, I'm going to give you, see, as we continue to go, you will learn a lot about surgery, and you need to understand that it is not, where you go simply cut and come back. There's a lot of thought process that goes behind it, right? Now, the first scenario that I would like to give you is, I have two patients, right? So let's say this is a patient with a breast, which is here. This is a patient number 1, and this is a patient number 2, right? Both of them have a lump which is going to be 4 centimeters, or let's say 3 centimeters to make it simple for you. This is the nipple areolar complex. And we all know that the breast is divided into 4 distinctive quadrants in this particular form, right? Now, I have two patients that we are going to depict. This is our patient number 1, and this is our patient number 2, right? So this is basically our scenario number 1, right? So I'm just picking up few scenarios so that we'll be able to understand. Now I told you that the lump is going to be present, and this time it is going to be a 4 centimeter lump. In patient number 1, a 3 centimeter lump is here, and patient number 2, the 3 centimeter lump is here. In both these patients, this is a 3 centimeter lump. This is a 3 centimeter lump, right? So you have two patients. The patient number 1 is having a 3 centimeter lump in the upper outer quadrant, and here you see this is going to cross two quadrants, right? Out of the patient number 1 and patient number 2, in which in which patient would you like to do a breast conservative surgery? A quick feedback. If you are watching live, I would appreciate if there's a small feedback from you guys. Out of these two patients, in which patient do you think we should do breast conservative surgery? Is it the patient number 1 or the patient number 2? We have just learned the indications, no? Quick feedback. Quick feedback. In which would you like to do a breast conservative surgery? Okay, now all those people who are saying, sir, we should do a breast conservative surgery in patient number 1 and not do in patient number 2, I would like to tell you that you're thinking wrong. Okay. Now the reason here is, what is the indication of breast conservative surgery? The size should be less than 4 centimeters, limited to one quadrant, no lymphovascular spread, non-pregnant female, and all that, right? Now you're saying, sir, okay, the first is less than 4 centimeters, that we can understand. In patient number 2, you can see it is crossing the quadrants, but you need to understand this quadrant division is an imaginary division. It's not an anatomical division. It is for us to simplify our treatment methodology. I have made these imaginary lines. What if, see, what was the condition? There should be two lines passing through the nipple perpendicular to each other. Itna hi condition tha. I'll just change this a bit into the orientation. Now you see, if I have one line which is going here like this, right? And there's another line which is going like this here. I have two lines which are crossing the nipple perpendicular to each other, also dividing the breast into 4 quadrants. So in this, if I make the breast in this particular form, you can see the lump is not crossing the quadrant, right? So either ways, you should do a breast conservative surgery. So remember, this concept is very, very important. So when you say not, it should not cross the quadrant, that means no matter how you draw, it should always, that's why size more than 4 centimeters usually tends to occupy more than one quadrant. 5 and above will definitely occupy it. So hence we do not go for breast conservative surgery. Did you understand? Clear hai? Chalo. So this is your scenario number 1, where you have two different lesions, but then again, because they're in the same context, मनदीप, मुझे ऐसा कोई मशरूम नहीं पता है, यू शुड आस्क अ फॉरेंसिक सर, ही वुड नो इट बेटर. तो वो आपको बेटर बता देंगे, मुझे नहीं पता बेटा ये ऐसा क्या मशरूम कहाँ मिलता है. ठीक है, अच्छा. दिस इज योर सिनेरियो नंबर 1, वेयर यू हैड वी हैड चैलेंज योर कॉन्सेप्ट ऑफ ब्रेस्ट कंजर्वेटिव सर्जरी. ठीक है, ओके. नाउ नेक्स्ट इज व्हेन यू हैव caused a defect, no, इतना तो defect बना दिया, right? So this is a defect. How do you cover this defect? Now this defect, the defect that we have created, you have to reconstruct it, no? So this defect has to be covered, and the manager, how do you cover this defect? We do something called as oncoplasty, right? So there are two types of oncoplasties. One is your volume displacement. One is your volume displacement. Another one is your volume replacement. One is your volume displacement, another one is your volume replacement. This is also called as a type 1 oncoplasty, and this is what we call it as a type 2 oncoplasty. Now the criteria is ki any patient who requires a volume displacement, that means there's loss of breast tissue. If there is loss of breast tissue less than 20%, then I would go with volume displacement. But if there is loss of breast tissue, more than 20%, then you would go ahead with volume replacement, right? ठीक है. So whenever you want to reconstruct this, there are two things. एक आपका volume displacement है, दूसरा आपका volume replacement है. Tomorrow when we talk about breast surgeries, I'll talk in detail that what is this volume displacement, what is volume replacement. Volume displacement is you adjust the breast tissue in the surrounding area to cover that defect. It is called as volume displacement. Volume replacement means basically you're trying to bring some other part of the body and trying to recreate it. For example, bringing a latissimus dorsi flap and covering the breast area to reconstruct that breast is called as volume replacement. Okay? So we'll try to understand the basic concept between volume displacement and volume replacement. That is tomorrow. So we had the first patient. In the first patient we spoke about that, in the first set of the stage that we have, the stage 1, stage 2A, 2B, that is your early invasive breast cancer. You have two options. One is your breast conservative surgery, another one is simple mastectomy. You now know that which one to pick. When do you want to pick a breast conservative surgery and when would you like to do a simple mastectomy? Okay? This is your step number 1. Now, once you have done with the surgery, that means once you have finished your breast conservative surgery, now you have to understand that you have to go into step number 2. Now, what is step number 2? It is your node assessment. Step number 2 is your nodal assessment. So when we talk about, see, in breast conservative surgery or in simple mastectomy, we did not understand or we did not address the lymph nodes only. Okay? Now you need to understand that even though you have removed the lesion, that is primarily the breast tumor or the cancer per se, did you address the lymph nodes? Did you remove the lymph nodes? Is there a requirement to remove the lymph nodes? Remember, every single patient who has a breast cancer need not undergo a lymph node resection, right? Because they are going to drain your upper limb. No, if you take it out, again, this is going to cause a lot of comorbidity after the surgery. You don't want that to happen to your patient. So how do you do a nodal assessment? Now, nodal assessment is done with the help of clinical examination. With the help of clinical examination combined with radiological assessment. So usually we do ultrasound of the axilla to see is there any enlarged lymph nodes or not. So on a clinical examination and a radiological assessment, you would see presence of enlarged axillary lymph nodes or there is absence of enlarged axillary lymph nodes. So what are you looking here? You're looking for enlarged axillary lymph nodes. You are looking for enlarged axillary lymph nodes. Either you can see that there is absence of enlarged axillary lymph nodes or there is presence of enlarged axillary lymph nodes, right? That means clinically you are able to palpate or radiologically you can see an enlarged lymph node. Now, if clinically, if it is going to be positive, it is called as a node positive disease. Here you have to take the patient for axillary lymph node dissection. You have to take the patient for axillary lymph node dissection. Here, you have to take the patient for axillary lymph node dissection. On the other hand, if there is no node positive, that means clinically, when you palpate it, you are not able to feel any enlarged node. Radiologically also, there is no enlarged node. But does that truly mean it is a node negative disease? What do I mean by this is, if clinically you are not able to palpate and radiologically you are not able to find there is any enlarged lymph node, does that truly mean that there is no tumor that has gone into lymph node? Can you be sure about it? Right? In simple words, if I tell you कि अगर lymph node palpable नहीं है or if it is not visualized on radiograph, do you really think it is a node negative disease? There could be a tumor that is sitting in a node not proliferated yet. Or वैसे भी if the node is not more than 1 centimeters in size, you cannot palpate it. So that does not mean it is node negative disease. So node negative does not mean it is actually negative. Node negative is actually does not mean it is node negative. That means it is having both the possibilities. Either it can be negative or there is a tumor that is present in the node. It is not enlarged yet, so it is not positive yet. For such patients, what are we going to do? For such patients, we will do something called as Sentinel lymph node biopsy. We'll do something called as a Sentinel lymph node biopsy. Now, the concept of Sentinel lymph node, it is the first set of lymph node to drain the tumor cell. It is the first set of lymph node to drain the tumor cells. to drain the tumor cells, right? So you will perform a sentinel lymph node biopsy. Again, an interesting thing, not every malignancy you can go ahead and do a sentinel lymph node biopsy. Now, the first ever sentinel lymph node biopsy was done in penile cancer. So, penile cancer was the first ever sentinel lymph node biopsy, and it is named after the surgeon who has done it. It is called as the node of Cabana. Do remember it. Now, other than this, it is done in breast cancer. It is done in malignant melanoma. It is done in breast cancer. It is done in malignant melanoma. It is going to be done in the head and neck cancers. Right? So it is done in the penile cancer. It is done in the breast cancer. It is done in malignant melanoma. It is also done in the head and neck cancers. So these are the sites where we will follow the sentinel lymph node biopsy. Now, when you talk about the sentinel lymph node biopsy, specifically when you're talking about in the context of the breast. So what are the various methods that you have? Now, let's understand the concepts and the various methods for sentinel lymph node biopsy. So, methods for sentinel lymph node biopsy. SLN stands for sentinel lymph node, and BX stands for biopsy. So what are the various methods by which you can do a sentinel lymph node biopsy? Now, the first or the most popular method that you have is what we call it as a dye-based method. Now, in a dye-based method, what are the dyes that we're going to use? We are going to pick any blue-based dye, right? We can use methylene blue. We can use an isosulfan blue. We can use patent blue. Any blue based dye is going to be taken. So how exactly is the sentinel lymph node biopsy is being done? You take this as the representation of the patient, right? This is your suprasternal notch. Let's say this is the sternum that is present. This is the clavicle that is there. This is the axillary groove that is present. And let's say this is the breast that we have. And let's say there's a tumor that is present here, right? And we all know that there are multiple lymph nodes. So when you say there are multiple lymph nodes which are here, right? So these are these multiple axillary lymph nodes, but I don't know in which do you have what, right? Now, in this context, what you'll do is you'll take this blue dye, whichever dye that you have taken. I'm going to inject the dye in the circumareolar region, and that too half an hour before the incision. Before you give any incision in the breast, I will inject the dye. Now, this dye is now going to go into the tumor, and from the tumor, it is now going to excrete into the lymph node. Whichever lymph node is going to turn blue, whichever lymph node it is going to turn blue, I am going to take that lymph node and send it for frozen section, right? So the basic concept is to give the dye around the circumareolar region half an hour before the incision. Before you put the incision, why half an hour before? Why not 24 hours before, or why not 10 hours before, or why not 2 hours before? So the objective here is the dye that is being injected goes into tumor, and from the tumor it drains via its lymphatics. Now all these lymphatics are intercommunicated. We have already learned in our anatomy, all these lymph nodes drain into central, central drains into apical, apical is again going to supraclavicular, internal memory drains into apical. There's a lot of inter-exchange. Now, if you give a lot of time, obviously the one node is going to get blue, from there few other nodes are going to get blue, and the entire set will become blue. You'll not be able to know which is the true node in which the tumor is draining. So half an hour gives me that adequate time that once I start dissecting it, so during that context, when you remove the specimen, reach down to the axilla, it takes another 45 minutes, right? So in half an hour to 45 minutes, I have reached there. So half an hour before the incision, and another half an hour to 45 minutes after the incision to reach to axilla. So you have good 1 to 1.5 hour time. That is adequate enough for it to reach down to the lymph nodes. And once you get these blue stained nodes, you'll send for frozen section. In the frozen section, my pathologist who is in the OT itself will tell you it is positive for tumor or negative for tumor, right? So in a blue based dye or the dye based method, I am going to inject the dye in circumareolar region, in a circumareolar region 30 minutes prior to incision. Now, if there is presence of a blue stained node, we are going to send it for frozen section. We're going to send it for the frozen section. Now, on frozen section, if it is positive for tumor or negative for tumor is what you have to look. So, when send it for frozen section, in the frozen section, you can say it is positive for tumor or whether it is negative for tumor. If it is negative for tumor, you don't need to do anything. But if it is positive for tumor, then here you have to take the patient for axillary lymph node dissection. You have to take the patient for axillary lymph node dissection. As simple as that. Okay. So this is our first method of doing a sentinel lymph node biopsy, and this is what we call it as a dye-based method. Right? Quite important. I hope everybody is clear with it. Right? Now, the problem with the dye-based method is, if you look at the complications, so nothing comes easy, no? So complication associated with the dye. Now, all these dye, because they're contrast dyes, they are associated in few patients with anaphylactic reaction. They are associated with the anaphylactic reaction. They are associated with skin tattooing. They are associated with the skin tattooing. That means it leaves a black mark. In fact, this is the most common complication. One of the most common complications for doing a dye-based method, it is going to be skin tattooing, and post-procedure patient can also complain about bluish discoloration of urine. This is bluish discoloration of the urine. So this is anaphylactic reaction. There is tattooing of the skin as well as bluish discoloration of the urine if you are going to use a dye-based method. So this is how you do a sentinel lymph node biopsy. That is your first method. The second method that you have, the second method for doing a sentinel lymph node biopsy is going to be with the help of radionucleotide isotope. So you're going to use a radionucleotide technique. So in a radionucleotide technique, they would ask you what isotope am I going to use. Now remember the isotopes that we are going to use. Number one, we can use a technetium-99 tagged with sulfur colloid. Same concept here. When the technetium is injected, it goes into the tumor with the sulfur colloid, excretes into the node, and you see whether it is node positive or node negative. Again, this is going to be injected. This is going to be injected in circumareolar region, around the areola. This is also going to be injected in the circumareolar region, right? Obviously, you will be using gamma camera to see the uptake. So if there is a hot spot on gamma camera, that is presence of hot spot, indicates node positive. Hot spot ka matlab hai, if there is presence of uptake and there is hot spot on gamma camera, it indicates patient is having a node positive disease. And if there's a node positive disease, you have to go and do an axillary lymph node dissection. That is going to be your technetium-99 with sulfur colloid, right? Achha. Apart from that, what are the other methods that you have? The third method that you have, it is going to be an ICG based method. Now ICG stands for an indigo cyanin green. And indigo cyanin green. It is an indigo cyanin green based method. ICG stands for an indigo cyan green method. In fact, this is a new method where you have there's a chromographic camera that is present. You inject this contrast agent, it goes into the node, and if it lights up green, it is positive. If it does not lights up green, it is negative. As simple as that is your ICG method. The last method is what we do it on our own center. We call it as the combined method. Now in a combined method, what are the two methods I'm going to do? In fact, the combined method is considered to be the best technique overall, where I am going to use a dye-based method, that is going to be your methylene blue, isosulfan or patent blue. Along with that, I am going to use a radionucleotide tracer. A radionucleotide tracer and ICG dye. Right? So if you combine all these, and this is what you call as combined method, a dye with a radionucleotide isotope with an ICG contrast dye is what we call it as a combined method. And currently the combined method is considered to be the best for sentinel lymph node biopsy. For the sentinel lymph node biopsy. Okay? So all my friends, how do you do a sentinel lymph node biopsy? Either you do a dye-based method, or you do a radionucleotide isotope method, or you go with ICG, or you go with a combined method. Isse zyada you don't need to pick across it. This is more than enough to understand, right? So in our stage, your 1, 2A, 2B, you did surgery, then you assess the node. That is going to be with the help of your clinical and radiological assessment. If there is node positive, go with axillary dissection. Node negative, do sentinel lymph node biopsy. On a sentinel lymph node biopsy, if node is positive, then you will go with axillary lymph node dissection. You will go with axillary lymph node dissection. That is going to be your nodal assessment, right? Now, once you are done with this, your job is done. So you have done the surgery, you have done the nodal assessment, and if the node is negative, you don't need to do anything about it. If node is positive, right? So what is this third step? So after doing a sentinel lymph node biopsy, if it is a node positive disease, for a node positive disease, one, you have to go ahead with axillary lymph node dissection. Axillary lymph node dissection. And also it would require a post-operative chemotherapy. A post-operative chemotherapy as well as a post-operative radiotherapy. If it is a node positive. If it is a node negative, you don't need to do anything, right? So this is with respect to your management of early invasive breast cancer. Now, next is going to be your locally advanced breast cancer. Yeah. We talk about the locally advanced breast cancer. So next we're talking about the management of the disease, where you have a patient with stage 3A, 3B or 3C, which is called as locally advanced breast cancer. Which is called as a locally advanced breast cancer. Right? So, how do you go ahead with locally advanced breast cancer? Now, for locally advanced breast cancer, our first step is start the patient on neoadjuvant chemotherapy. Start the patient on neoadjuvant chemotherapy, right? So what is this neoadjuvant chemotherapy? The concept of neoadjuvant, what does it mean? It means prior to surgery. So it is chemotherapy. It is chemotherapy prior to surgery. That is before the surgery. Now what is the goal? Now this is done to downstage and downsize the tumor. It decreases, or it basically gets you either to downstage or downsize the tumor, and it also decreases the vascularity of the tumor, right? So this is the concept of neoadjuvant chemotherapy. Now, what are the current indications? Where would you like to do a neoadjuvant chemotherapy? What are the present indications? What are the current indications for doing a neoadjuvant chemotherapy in a patient suffering from breast cancer? Number one is your locally advanced breast cancer that we just spoke about it. If a patient is having a disease that is 3A, 3B, or a 3C disease, I will go ahead with your neoadjuvant chemotherapy, right? On the other hand, there is a genetic component which we'll talk about in the molecular status, that is HER2 neogen if it is positive. For HER2 neo positive, again neoadjuvant chemotherapy should be given, right? Now, okay, whenever you are trying to, just to get the adequate size so that there is less loss for the breast, that can also be an indication. That is a large tumor, and patient insisting for breast conservative surgery, right? We just learned that breast conservative surgery cannot be done if the size is more than 4 centimeters. Let's say there's a 7 centimeter lesion and patient says, sir, I want breast conservative surgery only. So what are you going to do? You can say, okay, madam, we'll start a neoadjuvant chemotherapy and then we will reassess after 2 cycles, right? That is, after completion of 2 cycles, we'll wait for 21 days. Then we will reassess, and that is called as the criteria for reduction or the reassessment status. And in that, if the size shrinks for less than 4 centimeters, this becomes a candidature for breast conservative surgery, right? So these are the current indications for neoadjuvant chemotherapy. So the first thing, I'll do a neoadjuvant chemotherapy. The second step is going to be surgery, and in this stage, we usually go ahead with MRM, and MRM stands for modified. It stands for modified radical mastectomy. MRM stands for modified radical mastectomy, right? It is a modified radical mastectomy. Suyash, yes, you are the second person who are telling me to start the Harrison series by Santosh sir. I will request Santosh sir from all your behalf that today my class was buzzing with Santosh sir, come back, come back, come back. So we will ask Santosh sir to do so. Until then, we'll continue. See, we'll try to run the Harrison series also, but because we don't want to overburden it, so we actually kind of take switch between medicine surgery, so that you have that, a bit of cushion as well. Okay, fine. So MRM is your modified radical mastectomy. That is, your surgery is to be done. Now after the surgery, the third step, if you have done neoadjuvant chemotherapy, you have done surgery, then you'll go with adjuvant therapy. And adjuvant therapy is after the surgery. So it's a post-operative intervention or a post-operative component. So in an adjuvant therapy, you can give a post-operative chemo. You can give a post-operative chemotherapy based upon the receptor status and all. You can give a post-operative hormonal therapy. We'll talk about the post-operative hormonal therapy, and then you can also give a post-operative radiotherapy. The post-operative radiotherapy, right? So these are the various components that you can do as an adjuvant therapy, right? So this was stage 3A, 3B, 3C. The last one that you have is for stage 4. Now stage 4, it is associated with very poor prognosis, right? So usually here we will address only with palliative management. So stage 4, here we will go ahead with the palliative management. Here we go ahead with palliative management, right? Best supportive care. Say if the hormone receptors are positive. If there is a hormone receptor positive, then you will go with HRT, that is hormonal therapy. If the hormone receptor is negative, we'll talk about all these. What are these hormone receptors? Don't worry about it. hormone receptors are negative, then I would prefer chemotherapy. If there is presence of ulceration. Now, stage 4 disease with ulceration of the breast basically indicates that there is a local infiltration. Now, because stage 4 and I said don't do any surgery, that does not mean you leave the patient. That ulcer is going to be painful, it is going to cause discharge, it is going to bleed, there's a lot of problem. So if there's presence of ulceration in this, we do something called as a toilet mastectomy. We'll discuss tomorrow what is toilet mastectomy. For now, you remember, we only remove the lump. And like a simple mastectomy you do. Even though there are node positive, there is distant metastasis, everything is there. I'm not going to go because the surgery here is not done for curative intent. The surgery done here is with palliative intent. And my idea here is just to provide a little bit of comfort with whatever days the patient is left behind. For that, I'm just addressing it, and that is going to be toilet mastectomy. Okay? So this is how you will go with stage-wise management. So we learned that what will you do for stage 1, 2A, 2B, what will you do for 3A, 3B, 3C, and what will you do for stage 4. Now we use the word like chemotherapy, hormonal therapy, and radiotherapy. A quick word on the chemotherapy reagents, right? So when we talk about the chemotherapy regimen, that what drugs are we going to give, how long are we going to give, how many cycles are we going to give, all that will be done, right? Now, when we talk about the chemo regime, standard breast cancer regime that you have is what we call it as a CAF regime. CAF in C stands for cyclophosphamide. A stands for adriamycin. And F stands for 5-fluorouracil. So cyclophosphamide, adriamycin, and 5-fluorouracil is the standard chemo regime that we usually follow. In few patients, there is hypersensitivity or there is allergic response to adriamycin. In that, you can replace the adriamycin with methotrexate, and this will become CMF regime. C is cyclophosphamide, M is 5-fluorouracil, M stands for methotrexate. M stands for methotrexate. Now the latest regime that you have, or a newer regime, the newer regime that you have is what we call it as an ACT regime. In ACT, A stands for adriamycin, C stands for cyclophosphamide, and T stands for taxane group of drugs, and that taxane is going to be paclitaxel, right? So paclitaxel group of drugs, right? Now, what is this new regime, and why do you call it as regimen and all that? So let's try to understand that as well. Now, whenever you're calculating the dose of the chemo drugs, right? So the dose of the chemo drugs is based or calculated. It is calculated on the basis of body surface area. It is not calculated on the basis of weight, because most of the drugs that we calculate on the basis of weight. It is not based on weight, it is on the body surface area. That is point number 1. Now we give the chemo drugs on the basis of cycle. So we have something called as chemo cycle. Now what is this chemo cycle? That means whatever regime that you have, we have, let's say, either a CAF regime. This is one regimen that we follow. Either you follow a CMF regime, or either we are going to follow an ACT regime. So there are 3 drugs that we have to give. So what we do is we call the patient, we admit the patient on the day where you're supposed to give chemo, and we give all these 3 drugs at the same time, like one after the other, but in the same day. Now, once the patient receives this drug, patient goes back home and then comes back after 21 days. So what do you mean by this chemo cycle is? What do you mean by this chemo cycle is the day patient comes to the hospital. So let's say this is the day the patient is coming to the hospital, right? So let's say this is the day where the patient is coming to the hospital, and there is a window period between second visit, and the patient comes back again for a second visit, to the hospital, and then goes back again, right? Again comes back for the third visit. In that way, comes back for the fourth visit, comes back for the fifth visit, and then comes back for the sixth visit, right? We don't have space for the sixth visit, but we'll create space. Then comes back for the sixth visit. Now 6 cycles are there, so that is why I've got to 6 visits, right? So all these are your hospital visits, right? So what happens is, patient comes, this is the first visit, this is the first visit the patient comes. I'm going to give the patient the drug that you're talking about. Now that drug can be CAF, either you can give a CAF regime, you can give a CMF regime or ACT regime, and then you send the patient home. You ask the patient to come back after 21 days, and when the patient comes back after second day, 21 days, you give second cycle. So what is the second cycle is, you repeat the entire drug again. So this is the second time you're repeating, it's the second cycle. Ask the patient to go back home for 21 days and then come back for the third cycle. Again there is 21 days gap, then there is a fourth cycle, then there is a 21 days gap, then there is a fifth cycle, and there is a 21 days gap, and there is a sixth cycle. And this is what we call it as chemo cycle. That means either you choose a CAF, CMF or an ACT regime, but you ask the patient to come back to the hospital after every 21 days, and once the patient comes back, you'll give this set of drug every single time the patient comes until 6 times. And this is what we call it as a chemo cycle. This is what we call it as the chemo cycle. Now how do you know whether the patient is having any response to the chemo drugs that we are giving or not? And that is what we call it as the receipt criteria. Now what do you mean by this? It is response evaluation. It is response evaluation criteria in solid tumors. We call it as the RACIS criteria. It is a response evaluation criteria in solid tumors. Now, when would you assess the response, right? After how many days would you actually want to know whether the patient is responding to chemotherapy or not? So, the ideal time for assessment. Ideal time for assessment. The ideal time for assessment is after 21 days of second cycle. That's when the patient is coming for the third visit. No, in the third visit, before you give chemo, you do an evaluation. So after 21 days of the second cycle, so obviously patient does not need to come back again. No, if you call in between, there's a problem. So anyhow, the patient is supposed to come, and then you also do your response assessment on that 21st day. Now, there are different terminologies which we are going to use for the response assessment. The first one is what we call as CR, that means complete response. Now, complete response, tumor disappears. And the patient came initially, let's say there was a 5 centimeter lump. You started the chemo regime. After second cycle, you try to palpate it, you're not able to feel it. It is called as a complete response. Tumor disappears completely. That is called as CR. Then there is something called as PR. PR stands for partial response. PR stands for partial response, where there is decrease in the size of tumor. There is decrease in the size of tumor, and this decrease is more than or equal to 30% of its initial size, right? Now, what do you mean by this is, let's say there was initially a 10 centimeter lump. Now it has become a 6 centimeter lump. A 10 centimeter lump has now reduced to 6 centimeter. You can see that it is decreasing in size. So I cannot say there is no response. Obviously, the response is there, but it is not adequate. It is not, as it is desired. So here you can say the 10 is becoming 6. So 30% is nothing but 3. No, 30% of 10 is 3. If you minus that, the size should be 7. If it is less than 7, that means it is a partial response. That means reduction is more than or equal to 30%, right? Then there is something called as stable disease. We call it as SD. SD means stable disease. In a stable disease, there is no increase or there is no decrease in size. Even if it reduces, no, it is usually less than 30%. So even if it reduces, reduction is less than 30%, then it is called a stable disease. Now the one which I will never expect to happen to my patient, and that is called as PD. PD stands for progressive disease. PD stands for progressive disease. PD stands for progressive disease, where there is increase in size of the tumor of more than or equal to 20%. Right? So what do you mean by this? 10 centimeters becoming 12, 12.5, 13. So 20% of 10 is 2 centimeters, right? And that, if you add, becomes 12. So if the tumor is becoming more than 12, 13, 14 centimeters, then it's a progressive disease. A progressive disease indicates a poor prognostic marker, right? So complete response, sorry, there is complete response, there is partial response, there is stable disease, and there is a progressive disease, right? So all these conclude in the context of your assessment criteria. Okay. So this is how you're going to give your chemo drugs, and this is how you're going to, address it across. Now, how many cycles for each of them? Remember, CAF is 6 cycles, we say 6C. CMF is 6 cycles, ACT is 4 cycles. Now that is why ACT is now preferred, no, because you're giving lesser number of cycles, that means lesser toxicity due to chemo drugs, lesser, I would say side effects, and the better quality of life. So taking all that into consideration, ACT is now preferred over the other 2 regimens. Clear? Right? So this is all that you should know in the context of stage-wise management in the breast cancers, right? Thank you so much for joining today. Tomorrow we'll resume back at same 9 o'clock, and tomorrow we'll be talking about the rest of the management and the breast surgeries. Okay? So tomorrow tune in back for the breast surgeries. We'll talk about different types of breast surgeries. We'll talk about the complications, post-operative complications, its management, and the molecular criteria in breast cancer. Right? So we'll resume back tomorrow in the evening at 9 o'clock. Until then, thank you. Good night. Bye-bye.